Hello and welcome to today's webinar, the last webinar of the year 2018. My name is Martin Altersberger. I am here today to cover point-of-care ultrasound, and with me to cover emergency ultrasound is Tom Cook from South Carolina. Hi Tom, how are you doing?
Good morning, Martin. Happy holidays. Glad to see you again.
To you as well. Glad to have you with us. So today's webinar will work like I will start with a very, let's call it brief presentation. I will show you some patients and answer questions you asked beforehand. You're always welcome to ask questions live. Please do so. And the majority of time I will hand over to Tom that he answers all your questions and also the questions you asked beforehand. So I would say we start right away. My presentation probably take 5, 10, 15 minutes maximum. And then you have the chance to ask all your questions to one of the masterminds of third rock ultrasound, Tom Cook. So let's start with the first question. Michael asked it, and he asked, how do you use emergency or point of care ultrasound? So there are very many indications for point of care ultrasound or emergency ultrasound. Actually, those are synonyms. To just name a few or some larger groups, it's about resuscitation, it's about diagnostic, symptom or sign-based, procedural guidance, also therapeutic and monitoring, if you think about ICUs. And then I want to go to the next question right away, the therapy of tamponade in emergency. Raquel asked a question and I want to answer it with those loops. If you take a look here at the left side of the screen, here you see in the center there is a heart. This is a subcostal approach to the heart. Here you see the liver on top, and this dark area over here, that shouldn't be here. That's free fluid. So we see a pericardial effusion. But what we also see is the right ventricle over here is rather compressed during diastole. So if the right ventricle during diastole is compressed, we have the diagnosis of pericardial tamponade. So if the patient is hemodynamically unstable, you should perform a procedure to reduce the fluid in the pericardial sac. And that you can already see here in this 4-chamber view. There is again this black area over here, the 4-chamber view, and here you see something entering the pericardial sac. So there already you see that fluid is drained, and if you take a look at 2 more loops of this patient, you see again the center in the heart, the heart, the left heart, the right heart, and here the right ventricle already is expanding. So this patient already profits from the intervention. And just a few minutes later, if you look at the time code over here, there is actually not very much free fluid to be seen. Tom, I want to ask you right away, what do you think? Do you often perform a pericardiocentesis? Does that help your patients actually?
Well, it's always a rare procedure, and for most clinicians, this is going to be something they may do once or twice in a career. In my institution, we have such a high volume. We're seeing about 93,000 patients a year in a population of people who are very sick. But the 2 types of patients you want to be aware of, at least from my experience, are those who have some type of aortic dissection, particularly of the aortic root, where they're going to dissect down into the pericardial sac. And then the second one actually is people get ablation therapy for some type of arrhythmia. And 2 or 3 days later, those patients will show up and have fluid in their chest. And they'll be complaining of sort of typical things of chest pain and shortness of breath, and they'll be hypotensive and tachycardic. And those are the 2 situations that you need to be aware of when those patients show up, that needs to be really high up on your differential. But it always tends to be a surprise. Sometimes you have enough time to set up and do a very thoughtful, measured procedure. Sometimes you have to move so fast, you have to think very quickly about what you have available to help you to treat the patient. And just, one pointer I always make is what you basically need is a needle and a guide wire and a catheter, a fenestrated catheter. And if you think about that, for most people, that's very easy to do if you just take a central line kit and start the procedure that way. Trying to get a pericardiocentesis kit up, it takes a long time sometimes to get that from supply and set it up. And what you basically need are just those three things: a needle, a guide wire, and a fenestrated catheter. And you can start treating the patient and stabilize them to a point where you can get them to more definitive management.
Thank you very much for your input. You mentioned very, very important things. After procedure, as you said, you will encounter them quite often, that they're a little bit hypotensive after ablation therapy. Then you have to bring them back into the OR, for example. But yeah, overall, needle, catheter, and then let's go for the fluid. Good. The next question that was coming in was a little bit, how can I say, divergent. It was from Juan, and Juan asked, how can you see PE in echo? Now, what could a PE be? It could be a pulmonary embolism, could be, as we have seen now, a pericardial effusion or a pleural effusion. And let me show you some cases. Again, this case was brought by Sharif, and here you can see quite nicely free fluid over here. So this is pericardial effusion. Could also be, again, tamponade. Look at the right ventricle. It's not 100% sure if it can expand during diastole or not. So if this patient is hemodynamically unstable, you also want to perform probably a pericardiocentesis. And here on the right hand side, you see a really vast amount of fluid. So this might be a more chronic state, and you also see in the center a swinging heart. To move on, to explain quickly the pulmonary embolism, what can you see here? You see the large right ventricle over here and a D shape of the left ventricle. The same you can appreciate here in the four-chamber view again. It's a large right ventricle compared to the left ventricle is rather small. And especially again here, be aware of this D sign. So that's a rather quick and easy way to see a pulmonary embolism. But be aware, also in a chronic state of higher pressure, the D-shaped ventricle could be present. Of course, the right heart is also dilating. Now, pleural effusion, something you might encounter very, very often. Here you see a patient with atrial fibrillation. You see the deterioration in left ventricular function, also probably in right ventricular function. And here you see pleural effusion. So again, black area means fluid, a lot of free fluid. Dyspneic patient, perform a thoracocentesis, give them diuretics, and this patient will feel better. One more case I want to present to you from Wasim. Wasim also showed us a patient with atrial fibrillation. You can see it over here again. And the deterioration in left ventricular function again. And on the right hand side, you see very many B lines. So this is lung ultrasound. We have here the pleural line, rib and rib shadow, and all these white echogenic lines, they're B lines. So if you find many of them on both sides of the thorax, you have pulmonary edema or high suspicion of pulmonary edema. So to conclude this, you can see many obvious findings with just point of care ultrasound. I don't go into depth. And one question is coming in right now. I don't see a name, but the question is, what is the relation between BAT and the ultrasound waves? I guess we use in clinical day practice just a little bit of information about that. So bats use ultrasound to see the environment. We use ultrasound to see inside our patient. So the theory behind that is basically the same. Tom, you want to give a little bit of insight on that as well?
Well, I'll make the point with regard to pulmonary embolism. So
yeah, sure.
Pulmonary is sort of the boogeyman of medicine. It's very, very hard to diagnose often. And a couple of quick points. The first of which is that you can still have a pulmonary embolism with a pretty normal echo. In fact, smaller pulmonary emboli may not cause any change at all. So you have to still remain relatively suspicious of the diagnosis. The second thing is if you're more advanced and you have the ability to use color Doppler, if you just look at the tricuspid valve in one that maybe is a little more questionable for you, and you see tricuspid regurgitation and you think that's new, that should also be a tip-off for you that you may have a pulmonary embolism. And the final point is, if you think this is sort of a chronic state of right heart enlargement from pulmonary hypertension, what you'll typically see is a really thick right ventricular wall and a dilated right atrium, as opposed to a pulmonary embolus where there hasn't been the opportunity for the wall to thicken up and it'll look relatively thin. So it really takes a lot of practice. It takes seeing a lot of patients. It takes a little bit of intuition and a high index of suspicion, but it's a fantastic tool for somebody who has a moderate to large size blood clot to pick up early and start their treatment early and have a more successful outcome.
May I ask you, do you always perform when you have the suspicion of a pulmonary embolism? Also, you mentioned you don't see it in echo as clearly as in the example I showed you if the pulmonary embolism is not too large. Do you always use ultrasound to detect a deep vein thrombosis and also lung ultrasound?
Yeah, for the most part, it depends on the patient, but it's very easy to use ultrasound to look for deep venous thrombosis either in the legs or the arms. It's not a particularly extensive exam. It doesn't take more than a few minutes to do that. So if you think that's the source, of course, when you're using ultrasound of the heart and the thorax, it's not just pulmonary embolism you're looking for. You're trying to look at about 8 different things at once. So you may be looking for wall motion abnormalities, or poor left ventricular function, or pneumothorax, or pericardial effusion, or pulmonary embolism, or aortic disease. The list goes on, and that's why the technology is so incredibly important for what we do. But if for some reason something tips you off that it might be a pulmonary embolism, then you don't even clear, it may be worth your time to go ahead and examine the legs as well, just to see if there's any evidence of a clot.
Thank you very much, Tom, again. And I want to go back to the slide of the pulmonary embolism just for a brief second. What you can also see, what Tom mentioned for the left ventricle wall motion abnormalities. If we look at the right ventricle here, what we can see is the lateral wall here is basically not moving so much. Let's put it that way. And you see the apex. The apex is rather hypercontractile. That's the so-called McConnell sign. So there are many different ways that can point you towards a diagnosis. You have to know them and you have to find the differentials. Then let's go on with one more question I want to answer. It's about a panic attack. Patient comes in with a panic attack. Can we see a heart involvement? Luca was asking this, and here's the answer. I always love to show a Takotsubo cardiomyopathy. Takotsubo cardiomyopathy, a broken heart syndrome or stress-induced cardiomyopathy, is a wonderful example how stress or catecholamines can affect the heart. You see here in the apex, basically akinetic heart, and you see that the basal portions of the heart are more or less hypercontractile. What else can you pick up in this loop? You see here a SAM, a so-called systolic anterior motion of the mitral valve leaflet, of the anterior part of the mitral valve. And this is present in systole and therefore could cause dyspnea. So a symptomatic patient. Another example of a Takotsubo, a stress-induced cardiomyopathy, you can see here. This was actually a patient who lost his wife, and because of the emotional stress, here you can see the akinetic apex and again the hypercontractile basis of the heart. So to all our users, if you have live questions, please feel free to ask anytime. If you're interested in more depth of the cases, we are very happy to give you more information. So anytime a question comes up, just feel free to ask right away. I have seen before there are already about 80 users online, so let's have a nice discussion about emergency ultrasound. The last two loops I want to show you, again about a panic attack, a ventricle, left ventricle, rather small cavity, hyperdynamic and tachycardic. And what you also can see is here this SAM, the systolic anterior motion of the mitral, the anterior part of the mitral valve. Again, you have to look very closely. So also a panic attack, besides the panic that people or the patients are having, can cause symptoms through an organic manner. So also the heart could be involved. And there's already another question coming in. Naoto is asking it. Before I hand over to Tom, in an emergency or trauma, dyspnea, you see lots of pleural effusion. When and how you decide to drain it. Before I hand finally over to Tom, I want to give a little bit of insight how I would do it. If there's a trauma present and you suspect that this trauma was in the area of the thorax and you think it could be blood, drain it. If the patient is unstable, you have to help the patient. No matter what you do in this situation with a thoracentesis, you cannot do anything wrong. So now I want to conclude my part and give the word to Tom. Tom, you want to talk about emergency ultrasound, give some insight in the questions people were asking you. I'm really happy, I have to say it again, to have you here. And you want to say some words about third rock ultrasound, how you use ultrasound in your daily clinical practice, also maybe how you teach ultrasound to your doctors.
Well, thanks, Martin. I've been involved with ultrasound now for 23 years, and when I came into it back in the 90s, the equipment was, of course, very, very crude by today's standards. But it's been just a revolution of use, particularly in my field of emergency medicine, where it went from nobody using it to it being a requirement in the United States to complete training in emergency medicine. So you absolutely have to learn how to use the technology. And the utility of it just keeps expanding every day. It was very limited when I started back in 1996. We literally cannot practice our specialty without having the technology available for us in the emergency department. I worked the last 5 days, and I can tell you just yesterday during my shift, I did 15 to 20 ultrasounds on very, very sick patients. So the utility of it is just unbelievable. Anything from evaluating a patient who's very sick and in shock to a person who didn't have any intravenous access and was very tachycardic, had a reentrant tachycardia, the heart rate of 160. Nobody could get an IV in that patient for the first 5 or 10 minutes, and I was able to walk in the room and really within a matter of 3 or 4 minutes have a great line, and we were able to cardiovert the patient within the next 5 to 10 minutes. So the list goes on and on. I could talk about it for a lot longer than probably the people watching this want to hear about, but needless to say, I use it on almost everything. I can't find a reason not to. I always joke that I said, I'll do an ultrasound on your pet chicken if you want me to. But that being the case, I can only encourage everybody to get involved with this. It just opens up so much more opportunity for you in your practice in terms of what you can do and what you can accomplish.
Great. Thank you very much, Tom. Just want to mention we have now already 100 people watching. So please feel free, you have this once in a lifetime opportunity to ask Tom Cook in the US all your questions. Tom, you want to start with the presentation?
Yeah, that'd be fine, Martin. Why don't you go ahead and bring up our first slide? And so if you're just going to advance that, but I got a series of questions before I started this, and I just thought I would recognize those people. I actually don't have an answer for some of the cases, but if you'll just go back one slide for me.
Yeah, sure.
Alex, whoever Alex is out there, hope you're watching, asked for some tips on how to do lumbar puncture with guidance from ultrasound. And so if we'll look at our first case now, we're going to go ahead and take a look at a patient who's 68 years old, so a bit older, and morbidly obese, which in the United States is a problem for probably the majority of my patients, and comes in with a worst headache of her life. And she has a normal CT scan, but she also has this strong family history of cerebral artery aneurysm. So you're very suspicious, and you'd like to do a lumbar puncture on her to make sure that she doesn't have any evidence of bleeding, but it's complicated by her size. And so we'll review how to use ultrasound for lumbar puncture. And the first of that is what makes it so hard. And I've already alluded to the first one, which is just obesity. We have patients who weigh 150 kilos or so, and it makes it very hard. And then the second thing that causes problems with it is degenerative joint disease. And a lot of times obesity and degenerative joint disease go hand in hand, complicating the matter even further. But in terms of actually getting ready for the procedure, I typically have the patient sitting on the side of the bed. It makes your orientation a little bit easier to understand. And then from that, you're going to have to choose a transducer. And most people would typically reach for a linear array transducer on the left, but this will only work kind of in your smaller or sort of normal size patients. For the larger patients, you're going to have to use that curvilinear array probe on your right to be able to get the penetration. Yes.
I have to interrupt you quickly because Paula was asking a question. I think this fits in perfectly here. Which probe do you preferably use? So when we are talking about lumbar puncture, you already mentioned linear transducer, but also the abdominal transducer, the convex probe for obese patients, which I think is a really great tip. But overall, also in trauma, do you use the convex probe or you use the cardiac ultrasound for all the indications?
So for trauma, I actually use a phased array transducer for all of my exam, just because I need to evaluate the thorax as well as the abdomen, and you can get an adequate abdominal ultrasound with a phased array. With regard to lumbar puncture, it depends on your patient. So if I was going to do the procedure on you, I know you don't want that, but if I was doing the procedure on you, I would use a linear array transducer. It's perfectly adequate, and the spinal column is only 4 or 5 centimeters beneath the surface of the skin. But again, for a lot of my patients, and the one I'm talking about in this example, you're going to need a lot more penetration. And so you'll reach for a curvilinear array transducer. You might need to get 12 to 13 centimeters of penetration, and you're just not going to get that with a linear array transducer.
Yeah, exactly. Good. So there was another question coming in about pulmonary and thoracic ultrasound. I would say we answer the question after this case. So if it is okay for you, Tom, you can finish this case because now you're in a really good flow and I want to see how you do it with this patient.
Sure. So if you go back to that slide of the transducers, and the next thing we have to do, go ahead and advance the slide there. The next thing we have to do is just understand a little bit of the anatomy of the spinal column, and I don't think that's something that's on the tip of everybody's tongue, or they keep it, or they've memorized it all those years ago in medical school. But there are two things you have to be aware of, and one of those is the spinous process. That's actually what you're going to look for, is that spinous process. And you also need to be aware of the lamina, which are at the base of the spinous process. Now, if you go ahead and advance the slide, the other thing you have to be aware of are the muscles on either side of the spinous process, and these are the erector spinae. They're really large, powerful muscles that allow us to extend our back, particularly our lumbar spine, and they will show up quite prominently on the ultrasound that you're going to do for this procedure. So if you advance the slide, here's a sagittal cut of the lumbar vertebra. And we need to be aware of a couple of different structures here. These are all ligamentous structures. There's the supraspinous ligament, which goes along the tips of those spinous processes. The interspinous ligament, which is between those spinous processes. And then finally, that big, thick ligament, the ligamentum flavum, which is what the needle tip passes through to go into the spinal column and gives you that characteristic pop you get when you actually do this procedure. So if you advance that slide, Here is sort of an image of what you're trying to do with what we most often use for this procedure, which is a midline approach. So essentially, you're going to take the needle and enter the skin exactly perpendicular, or rather parallel to the spinous processes and perpendicular to the lamina. And this is what most of us tend to do when we do this procedure. Now, there is another approach, if you advance that slide, called a paramedian approach. I've only done this one time, but the literature says it's actually quite a bit better. And what you're going to do is come in just off center from the spinous process. And it's felt to be a better procedure. If you'll advance that slide, it's felt to be a better procedure because you avoid some of these ligamentous structures, particularly in older patients who have a lot of a calcification of these ligaments. This is thought to be better. And it's theoretically gives you a larger target area because you're going right over the lamina, and also less pain in older patients. And so when you do this procedure, what you're going to do is find the tip of the spinous process and then go a centimeter lateral and a centimeter inferior, and then sort of angle towards the baseline. Now, again, I don't profess a lot of experience with this. I've done it one time in a patient I was struggling with, and it did work. But I usually use the midline approach, and it works just fine. Okay, so this is a typical picture, a sagittal cut of the lumbar spine. And what you can see there quite obviously are the two tips of the spinous processes. And one thing you may note is that there's not a lot of distance from the transducer surface down to that spinous process. It's just going to be less than a centimeter. And this is a normal, sort of a normal sized person. Now, if you go to the next slide, what you're going to see is how it looks in the axial plane. And so now what we're trying to do is pick off the tip of that spinous process. You can see it right there. You see a nice acoustic shadow below that. And that's what's going to tip you off that you're over the spinous process. And then there are two bright images at the base of the spinous process. Those are going to be the two lamina. And then between or on either side of the spinous process, you see those marbleized structures, and those are the two erector spinae, and they really show up and they really give you the opportunity to figure out where you are. And those three structures right there, the lamina, the spinous process, and the erector spinae, that gives you, that orients you to where you need to go. And now you're going to be ready to figure out where to put the needle. So the next tip is when you find that spinous process, you're going to lower the transducer so the tip goes away on the screen, and that tells you that you are, in fact, in the interspace where you can put the needle into the skin and you will not hit the spinous process, and you'll be able to take that needle and place it into the spinal column. So that's the area you need to figure out how to mark or how to identify when you go back and to actually do the procedure. So if you advance a slide, here you see an example of how different it is when you have somebody who is obese. So on the left, you have a normal sized patient. So that's probably what Martin's back looks like right there. Only a few, less than a centimeter of soft tissue over the tip. And then if you look on the right, this is an obese patient where now you have quite a bit more soft tissue. Sort of the darker area is adipose. So that's fat. And then as you go down, you got these more hyperechoic structures before you see the actual tip of the spinous process. Go ahead and advance the slide. And now you see this is actually, you'll notice a couple things. One, you're using a curvilinear probe. Look at the footprint itself. It's curved. So this tells you that you have a curvilinear probe. Your frequency is a lot lower, so your resolution is a lot lower in this patient. It's not going to be like a linear array transducer. And if you look over there on the left, there's a bright object about halfway down the screen right there. And that is the tip of the spinous process. So one thing, it's not as easy to see, and you can see how far away it is from the surface of the skin. So you're going to have to take that needle and go a lot farther into the skin to be able to get into the spinal column. Next slide for me, please. This is the axial view. And so now it's very hard. If you look right in the middle of the screen, there's a little bright white. That's the tip of the spinous process right there. So you can see, wow, it's a long way from the surface of the skin. And once again, look at the two erector spinae on either side of that spinous process. There's sort of these big round structures. That's going to tell you that you're in the right spot. And once again, you're going to move that transducer towards the head, towards the feet until the tip of that spinous process goes away. And that's where you're going to direct the needle to go to do your lumbar puncture. Okay, next slide. Here we can see how far that distance is. So if we look from the surface of the skin down to the tip of that spinous process, 6 centimeters. That's just to the tip of the spinous process. And your average spinal needle is about 8.5 centimeters. So you really don't leave yourself a lot to work with once you place this needle into the spinal column. You might actually have to push the hub of the needle into the soft tissue to be able to enter the column. And this is very frequent for me. Or we have to get a special needle. We can get them up to about 12 centimeters for some of our patients. So there's 2 different methods you can do almost any procedure with ultrasound. And there's a static and a dynamic. So a static means you're going to essentially mark the skin and figure out where you're going to place the needle to do the procedure. And then you're going to not use ultrasound anymore, but just go ahead and do the procedure based on those landmarks. So here you can see I have an axial plane. Go back 1 slide for me, Martin.
Yeah, sure.
Here you have a sagittal cut, so it's hard to see, but the operator is marking the skin, basically where the spinal column is in the sagittal plane. And then the next slide, you can see that the transducer will be turned, and now you have an axial plane, and you'll go ahead and mark the skin again. And then the next move is simply to go ahead and connect those two lines, and essentially X marks the spot where you're going to put the needle. Go ahead and advance that slide for me. There you go. Now you have an X marks the spot, and now you would basically put your ultrasound away and go ahead and start the procedure. Now there's obviously the tricks with a lot of these sorts of things, and I'll throw a few what we call pearls at you. One of those is how you mark the skin. You have to come up with a system that makes sense for you. This is basically the one I use, where I mark where the tips of the spinous processes, so sort of in a vertical alignment. And then I mark where the spaces are between the spinous processes with a horizontal line. And then I put a little curved line in there, and that tells me where each of the lumbar spinous processes are. So you can see that marked on this slide. And so what I'm going to do is place my needle at the horizontal line in line with the vertical line to do the procedure. And almost always you're able to get what you need done, even on very challenging patients.
So a quick question, Tom.
Sure.
So you also do that, how you mark it, you also do that in obese patients?
Yes. You're going to mark it in obese patients. You have to use a special skin marker. The transducer gel pretty much dissolves almost any other kind of marking pen. So you have to get a skin marker. But yes, once that's done, you simply put the ultrasound away and set up like you would do any other lumbar puncture that you've done all these years. And it works very, very well. It's pretty slick to do. And it's usually a procedure where nobody else can get the procedure accomplished, and you walk in and do it. And it's a great feeling to be able to accomplish that when nobody else could do it.
It's a great feeling, and it's a really, really valuable tip. Thank you very much for that. And I just wanna point your attention before you go to the case 2. Karina was asking, can you give us some highlights on thoracic or pulmonary ultrasound? Thank you.
Well, I mean that question is so broad. You could spend 2 days of lectures and talking about that. Of course, anybody who has sort of any thoracic symptom, the benefits of ultrasound are tremendous. You know, the sort of the traditional way that we image patients and evaluate patients really isn't adequate anymore. If you think of what we've had for years and years with a stethoscope and an X-ray machine, both of those just really don't work very well for a lot of these very sophisticated problems. If you want to throw in an EKG, again, it gives you a lot of important information, but it also doesn't give you a lot of information about certain pathologies which are very dangerous. So if you think about the combination of your physical exam, an EKG, and an ultrasound machine, boy, it really helps you when you go into that room and your differential is 8 or 9 possibilities for somebody who looks sick. And it really helps you direct management. Some of those times you'll go in there and you'll see a large pulmonary embolism, or you're seeing pneumothorax, or you'll see a bad pericardial effusion, and you know that you have to treat that person almost immediately. Lots of other times, the vast majority of times, you can go in and you don't see anything, but you're mentally checking off all of those bad diagnoses, and you're putting a line through them saying, I don't have to worry about this, and I don't have to worry about that. And I think that's the biggest advantage when you're doing when you're using the technology, is that you've got all these possibilities in your head, and you're walking in there and just marking them off your differential within a matter of seconds. A thorough cardiac and pulmonary exam from an emergency physician standpoint should be no more than probably 4 to 5 minutes. And you have ruled out a number of very, very serious diagnoses, and it really helps you hone in on what you need to do. And also it allows you to move to the next patient and take care of them. So that would be the biggest thing, is to invest time and effort into learning how to use that. And you will not only be much more precise in your evaluation and management, but you'll be much more efficient in your patient care.
Definitely. I want to just bring up one point. You mentioned a lot of very dangerous diagnoses like a pulmonary embolism or pneumothorax, but also, for example, a pneumonia. You can scan a pneumonia before the X-ray detects it. And the X-ray is really bad in detecting pneumonias. So there you can help yourself, especially during night times or in a stressing situation, to just get an overview where the pathology really lies, and you can detect pneumonias with ultrasound really nicely. Would you agree, Tom?
The caveat with pneumonia is that it has to be what's called pleural based. And so what that means is that the infiltrate goes all the way to the visceral pleura adjacent to the chest wall. So if there's any air between the visceral pleura and the actual pneumonia, you won't see it because the air reflects the signal. So a parahilar infiltrate you will not see. A sort of a left lower lobe or a right lower lobe pneumonia, sometimes a right middle lobe pneumonia, you'll be able to pick those up pretty well. The sensitivity is probably not, even for those infiltrates, is not as good as X-ray. Now, ultrasound is much better at detecting pleural effusions and pneumothorax, and most likely pulmonary edema. We're seeing more and more evidence of that. Mm-hmm. So if you think of the 4 sort of primary pathologies you're concerned about, which would be pneumothorax, pleural effusion, pulmonary edema, and pneumonia, ultrasound is better for 3 of those right off the bat. So again, if you're worried about pulmonary pathology, and I see this as a matter of routine in my practice, people come in with a lot of I see a lot of people with heart failure. They don't feel very well, but there doesn't appear to be anything changed. And we'll go in within a matter of seconds. I mean, like 10 seconds. You'll walk in and say, oh, their whole right hemithorax is full of water, full of pleural fluid. And we already know that patient's getting admitted. And so, again, it creates this sense of efficiency where you can move through the case very, very quickly, and you know what the final disposition is going to be for that patient.
Exactly. Already the time is 5:34. 160 people are watching. Thank you very much for your questions already. And I just want to point to you really, really briefly that we also have the New Year offer running. So if you take a look at all our online courses, we have up to 30% of a discount. There you can see Echo T, also as we are talking about point of care ultrasound, pediatric emergency ultrasound, also the emergency ultrasound bachelor class, and many more courses. Check it out. And Tom, I think you can continue with the second case you brought us.
So the second case is another one that's really unique. I actually took care of a patient just like this about 10 days ago. And it's a 24-year-old guy who comes in, and he says he has the worst sore throat of his life. And he has a very characteristic voice. He sounds like he has a hot potato in his voice, so he's kind of talking like this. And it's pretty obvious that he has an upper airway problem. And he also has a little bit of drooling. And so you immediately become suspicious that he has a peritonsillar abscess based on his presentation. And now, I can certainly remember when I was a resident and a younger physician, I was always challenged by this for a couple of reasons. One, you weren't ever really sure they had a peritonsillar abscess unless you put a needle into it. And the second was that the ears, nose, and throat doctors were very reluctant to come in and take care of the patient and treat this because they didn't want to come in and be woken up and so forth. So what's fascinating is that over the last 20 years or so, the initial treatment of this has completely come to emergency physicians. We do almost always do the initial treatment on the patient, and largely this has been accomplished because we are able to use ultrasound to help us with the diagnosis. So when you're using it, it's just fantastic because, one, you can identify the pathology, but you can also make sure that you don't have one very serious complication, which I'll show you here in just a second. So if you go back to that last slide where it says, sort of why ultrasound, and then we'll pick it up from there. Go ahead and advance that slide. And so the biggest thing, as I alluded to, is you need to be able to differentiate whether you actually have an abscess or this is just sort of cellulitis of the soft palate or the peritonsillar structures. And on the left is cellulitis if you're experienced in seeing cellulitis. And then on the right, you have an anechoic area, which is full of fluid or pus in this situation. And so this is the key in terms of sort of making the diagnosis. You don't need to be putting a big needle into somebody's pharynx if they don't even in fact have an abscess. And so in order to set up for this procedure, you have to keep one very important thing in mind, and this is the complication, which is that you don't want to hit what we call big red. You don't want to hit the carotid artery. Especially, you don't want to drive a needle through a bunch of pus and then put it into the carotid artery and shoot that pus around the brain. So this ultrasound, again, gives you the ability to not have that problem. Now, there are going to be situations where you just can't do it in an emergency department. I can't do it in my setting if they have altered mental status or they have so much trismus they can't open their mouth. And the patient I did 10 days ago had a lot of trismus, but we were still able to get his mouth open up far enough to accomplish our procedure. Or you really think that their airway is so unstable that it's too risky to do as an outpatient. The other thing is that they have to be able to cooperate. So if they're really upset or they're having a lot of pain or they can't hold still, then you're not going to be able to do this in an outpatient setting or in the emergency department. But in order to set up for the procedure itself, we're going to use an intracavitary probe. Now, your choice of words here is pretty important. A lot of people would call this a transvaginal probe. Patients, if they hear the word transvaginal, they get kind of upset about that, and they don't want you to use that. So that's understandable. But you want to say intracavitary, and then you need to put a cover on it. And so there are commercial covers, which you see on the top of the slide. But they're also what I've used for the last 25 years. I just use an exam glove, and it works just fine. And it doesn't cost very much, just a couple of pennies. And then once you do that, you're also going to need to choose some kind of a needle to aspirate all the pus, and we're going to use basically just a spinal needle to do that. Now, the way you'll actually do the exams you see here is you'll hold the transvaginal. There, I said it. You don't say that word. Intracavitary. You're going to hold the transducer and place it in the mouth so the tip of the transducer comes into contact with the pharynx. And a lot of patients struggle with this, so you're going to have to kind of negotiate with them to try and remain calm, have them breathe through their nose, and a lot of them will gag, and we'll give you a little tip here in a minute about how to avoid that. So this is actually what you're trying to see. In the area just beneath the transducer, there's a round area right where your cursor is now. That whole area, that's abscess, okay? And that is sort of a heterogeneous picture when you place it right there. But if you look right below that abscess, there's something pulsating down in the bottom part of the screen. That is what you don't want to put your needle into. That would be really, really bad. That's the carotid artery. And if you advance the slide, you'll see that we have color flow on that, and you can say, okay, I definitely don't want to put my needle in there. So I have to figure out a way to keep the needle from going too deep. The patient could move suddenly. You might slip yourself. You just don't want to drive that needle past the abscess and get into a lot of trouble. So we have to come up with a strategy, and we're going to show you just exactly how to do that so you don't put that needle through the abscess and right into the carotid artery. So if you go ahead and advance that slide for me, we'll give you these very important pearls. This is, this is a lifetime of experience how to avoid trouble. The first thing we do with this is we get some, we call it Ceticaine. It's just a topical anesthetic. and we spray it into the back of the mouth, and this helps with the patient's gag response when we do the ultrasound. So that's kind of sort of the first tip on that. The next thing I do is I put a little bit of lidocaine into the end of the syringe that I'm going to use to aspirate the pus. And what I do is I just poke the needle into the mucous membrane, put a little bit of lidocaine in there to numb up the area a little bit more before I advance the needle into the abscess itself. And the next tip is probably the most important. So we're using a spinal needle, and spinal needles are packaged with that hard plastic sheath that you see there on the left. And what we do is we figure out, based on our ultrasound, how deep we need to go to get the tip of that needle into the abscess. And we will trim that hard plastic cover and then put it back over the needle. So now what we have is a situation where we can't even get close to the carotid artery. It's simply impossible. And this is an extremely important tip for you to avoid complications. So you can see all we do is take a pair of scissors and cut that. And it's really quite elegant when you can do that and you feel comfortable that you're not going to hurt your patient. So this is a young woman. She's a college student. She has a peritonsillar abscess. We've already figured out where it is on ultrasound. You can see the cover on the needle. And here you can see we've aspirated out that pus. See the cover over the needle? We can't get too deep with her. We can't cause any problem with the carotid artery. She's a very cooperative patient. And we aspirated out about 4 or 5 cc's of pus. We gave her some steroids and some antibiotics. She felt much better. We sent her home and came back the next day, and she just did fantastic and was completely fine in about 48 hours. So it really, again, this is one of those things that gives you a lot of gratification. It's just a wonderful trick for those patients who have that problem.
This is actually a really great tip, to use the hard plastic. Just cut it a little bit, and then you never really, as you said, you never have the chance to even get to the carotid artery. So that's an amazing tip. 2 more questions are coming in. The first question was asked about airway ultrasound. Now we are talking, we are in this area to even use a transvaginal probe. I call it now that way, I'm sorry. But do you also use airway ultrasound to identify, for example, if you intubate the patient correctly?
So there's a lot of literature that does this. I've done it only a few times. In general, the idea is that you're going to use a linear array transducer over the trachea. And if for some reason you put it down into the esophagus and you weren't able to figure that out, you would clearly see the endotracheal tube as a bright white signal adjacent to the trachea. I don't have a slide or a picture prepared. It's actually not that complicated. You can Google that image or pull up a number of different papers on it. We're, in my institution, really pretty sophisticated with airways. We take care of a lot of really beat up people, and we use a lot of video laryngoscopy. So the number of times I reach for this is pretty small, because we actually fortunately are good enough that we don't have problems figuring out if we missed or not. But it is not hard to do. And if you just go Google an image of that particular image, and you'll find it. Basically, I would just Google something along the lines of endotracheal tube ultrasound as your keywords, and it'll show you a picture of that.
I think you summarized it perfectly. It's actually not hard to do, and also easy to try if you want to, but don't intubate your patient wrongly. Another question came in from Fernandez about spleen rupture. So I guess it's a question about, can you see a ruptured spleen with ultrasound?
Well, the answer is yes, but don't rely on it. So spleens are notorious for looking completely normal when they've just been broken in half. And so the message here is very specific. If you see it, there's something wrong, but very insensitive. So if you don't see something, you still need to get a CT scan to make sure there isn't a splenic injury.
Great. So time goes by very, very quickly. It's already 5:50 p.m. here in Austria. Tom, you want to continue with your third case?
We can do that. I think maybe this will be a nice wrap up for us. Let's
Great,
go ahead
amazing.
and do. So this is a little bit of a musculoskeletal case. It's something that's very common. And I actually had this case two days ago with a guy who fell down some steps. But this is a 32-year-old woman, and she was just going down the stairs, and she felt a big pop in her knee. And what's interesting about her is that she had a urinary tract infection, and she was taking a fluoroquinolone, which we know causes inflammation of ligaments. So here's a situation where you're kind of suspicious that you have a problem with the patellar tendon. And so we go ahead and do an ultrasound using a linear array transducer. You can see the placement of that. And this is the picture that you'll get. And just to point out a couple of things, go ahead and hit the click button there for me, Martin.
Yeah.
There's the patella. So the patella is a very hyperchoic structure with shadows. You're going to see the surface of that. And then attached to that is the patellar tendon. And if you notice the orientation, the left side of the screen is towards the patient's hip and the right side of the screen is towards the patient's foot. So we've identified the patella and we've identified the patellar tendon. And then if you go ahead and advance your slide, you'll see that we've picked up the tendon and we start moving towards the foot, and we see the tendon, and then whoops, it's something's wrong right there. So go ahead and advance that slide for me. And what you'll see here is we're actually passively extending the lower leg, and we can literally pull apart the two pieces of the tendon. If you actually look, you can see blood floating around in that gap where the tendon's been torn. And so, again, this is one of those things where you might be able to make the diagnosis by physical exam, but a picture is worth 1,000 words. You literally put that transducer on there. You go maybe 15 seconds in the examination. You know exactly what's wrong with this patient, and so you can quickly figure out the disposition for her, which in this case was to splint her leg and have her follow up with orthopedics.
Tom, I have to say a really great case, basically a very, very good wrap up. But one more question that just came in from Dr. Netsu. What was the most impressive finding you had in emergency ultrasound?
Oh, I think it's like the question I get is like, what's your favorite country you've traveled to? Because I like every country I travel to. They're all a little bit special. And so to pick one, it's just it's impossible. I've done this for 23 years, and I had a bunch of great cases yesterday. I think what's actually the most impressive thing to me and the most exciting thing is when I can go immediately to the bedside and see a patient and very, very quickly come up with an effective evaluation and management plan. And patients just love ultrasound. We as a human species, we just like looking at televisions and looking at pictures, and we like looking at ourselves more than anything else. And when you can sit there by the bedside and show that patient exactly what's wrong on a picture, there's nothing quite like it. They really, really feel connected to you. They really, really appreciate the time that you put in to show them that. It gives you an opportunity to connect with them on an entirely different level. But these few cases I've had here, I've had hundreds and hundreds of them like it. And in my field, because we do everything from cardiac all the way through every single realm of ultrasound, it is so gratifying to be able to use the technology and connect to my patients in such a special way.
Yeah, I think that is a really, really nice wrap up. Sorry, there's another question coming in. Tom, you want to answer one more question?
Sure.
Great. So what is the most specific sign for cardiac tamponade? Herman was asking this. Yeah, sorry.
Yeah, I think you answered this nicely in your segment, which is it's this anechoic material collecting outside of the right ventricle. So in a lot of these patients, it's challenging, particularly with different views, to figure out how much if fluid's there, and then sort of quantitate the amount. Now, certainly when there's a lot of fluid there, and you have tamponade, it's not hard. You can use any view you want. But the one we tend to reach for the most in terms of quantifying and to make sure it's not there is that subcostal view, because you get a really clean image plane between the left lobe of the liver and the free wall of the right ventricle. And so those are the ones you tend to see in the textbook the most. That tends to be one of the views that you can also use if you want to try and aspirate that, although it's not my first choice. There are basically three different approaches that you can use for pericardiocentesis. But it's that anechoic line between the left lobe of the liver and the free wall of the right ventricle on that subcostal view.
Great. I also think that is the perfect answer. I would maybe also add the McConnell sign. Sometimes you can see it. If you see it, it's also, sorry, now I'm at the Peri, at the pulmonary embolism. There was another question coming in. I'm really sorry, Tom. Pulmonary embolism also as well, the McConnell sign for the pericardial tamponade. If there is some kind of fluid and the right ventricle is compressed and not able to expand, then you have the diagnosis. So I think time went by really quickly. Tom, thank you very much for being here. I have to say thank you to the audience as well for all the questions you were asking. It was very interactive. And also this webinar will be displayed in detail. So there will be a recording of this webinar also available and will also be sent to all the people who joined the webinar. Thank you very much from my side. Again, Tom, thank you very, very much for joining me here today. And to all of you, have a great year 2019.
Thank you, Martin.